Hello everyone, my name is Vanessa Shador and I'm presenting an adult pulmonary case. My patient's name or initial is DW, age 59 years old, race African American, sex is male. He came to the clinic by himself and he is a reliable historian. His chief complaint is, I am having trouble breathing. So, TW has a known history of COPD not requiring home supplemental oxygen. He presented with increasing difficulty breathing over the past 2 weeks. He described his shortness of breath and increased work of breathing associated with generalized weakness. The symptoms were reported as persistent throughout the day and it worsened with exertions such as walking short distances and were partially relieved by the rest and use of rescue inhaler, which he reports using more frequently than usual. He reports having a dry cough occasionally. He denies wheezing, sputum production, fever or chills, and chest pain. He reports adherence to his prescribed COPD medication. He denies recent upper respiratory infections or known environmental triggers, including strong perfumes, smoke, or pollen exposure, and had no recent outdoor or wooden area exposure. He also reports being a non-smoker. His past medical history includes hypertension and hyperlipidemia and currently taking Lipitor 20 milligrams orally every night, lisinopril 10 milligrams orally once a day, and albuterol 90 mcg 2 puffs every 4 hours as needed for shortness of breath. He also does have allergies to hydrochlorothiazide. He had no history of surgeries and hospitalization. He denies using tobacco or vaping, denies alcohol and illicit drug use. He has regular diet, eats fruits and vegetables. His family history includes a mother with hypertension, maternal grandfather has hyperlipidemia and asthma. His vital signs were temperature of 98.6, blood pressure 134/70, respiratory rate of 18, heart rate of 92, oxygen saturation of 94% on room air. His height is 5 feet and 7 inches, weight of 233 pounds, which gives him a BMI of 36.5%, so he has obesity. Review of system is notable for his reports on shortness of breath and fatigue. He denies eye itching or vision changes. He denies ear pain, ear discharge, nasal discharge or congestion. He denies sore throat or difficulty swallowing. He reports no chest pain, no palpitation, or syncopal episodes. He reports on dry cough with no sputum production. He denies heartburn, nausea and vomiting. He denies headaches or dizziness. He denies anxiety or mood changes. He also denies joint and muscle pain, and he denies unusual bleeding. On physical examination, the patient appears well-groomed with no respiratory distress. The neck is supple without pteromegaly or jugular venous distension. There is no maxillary tenderness. Respiratory effort is unlabored with symmetrical chest wall expansion. However, breath sounds are diminished bilaterally on auscultation. Cardiovascular examination reveals regular heart rate, rhythm with normal S1 and S2 heart sounds. There is no peripheral edema. The skin is pink, warm, and dry without pallor. The patient ambulates independently without difficulties. Neurologically, the patient is awake, alert, and oriented. Patient's mood and affect are stable with no behavioral abnormalities observed. So based on history of COPD, diminished breath sounds on exam, absence of fever, no productive cough, no chest pain, and no signs of fluid overload like peripheral edema, his most likely diagnosis is acute exacerbation of COPD. Other differentials implicated in his case are community-acquired pneumonia. His diminished breath sounds could present developing consolidation or poor air entry. However, the absence of fever, chills, and sputum production makes this least likely. than COPD exacerbation. Other implicated differentials to include are electrolyte imbalance. The patient is currently taking lisinopril, which can decrease aldosterone secretion, leading to retention of potassium by the kidneys, result that leads to hyperkalemia that can cause generalized weakness and fatigue. Also, anemia can cause fatigue and dyspnea due to decreased oxygen capacity or carrying capacity, which could be explained if there is low hemoglobin, although he has no pallor on examination, no history of bleeding, and no other systemic signs of anemia. So the plan of care includes chest x-ray to rule out other pulmonary pathology, CBC to assess for anemia, and CMP to rule out electrolyte imbalance. For medication, short-acting bronchodilator, albuterol 90 mcg, HFA 2 puffs every 4 to 6 hours as needed for shortness of breath is continued as a rescue inhaler. Then start Breo Ellipta 100 microgram per 25 microgram, 1 puff daily for long-term control. This medication is a combination of inhaler containing fluticasone fumarate. It is a corticosteroid to reduce airway inflammation, and vilanterol, a long-acting beta agonist to relax airway muscles. And patient will continue other medication. His lisinopril 10 mg daily for hypertension and Lipitor 20 mg nightly for hyperlipidemia. Supportive care is given, which includes educating the patient on avoiding extreme hot and cold weathers. We'll encourage the use of pulse oximeter to monitor oxygen saturation and assess if there is a need for supplemental oxygen at home. Encourage pneumococcal vaccination per CDC guidelines. Reinforce medication adherence and educate on proper inhaler technique. Continue reinforcing non-smoker status, and will consider referral to pulmonology for a long-term COPD management. He will have a follow-up in 1 month and advise the patient to report earlier if there is fever and sputum purulence. All right, that's the case. Thank you very much.